Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 165. We have a very highly educational case for you today of cases which I am sure you are finding more and more in your practice. It involves the best management for an underexpanded stent. What exactly is the right way to treat it, the role of imaging, and there is a whole lot of arsenal at our disposal these days, whether there should be a combination of rotational ablation, IVL, maybe orbital atherectomy. A lot of these you'll get a chance to understand today. With this introduction, let me take you to the Cardiac Cath lab where Dr. Kinney and Dr. Sharma are standing by. Samin, good morning.
Okay. All right. Good morning, all the viewers. And again, something different we are showing today. And that will be basically this unexpanded stent. Actually, it is my technique of SKS, simultaneous kissing stent. We did it restenosis at that time, went for CABG. Then graft to the diagonal is good, but which is occluded, but LAD LIMA, which supplies it close. So now we have to tackle the old SKS, which is the two-layer, the carina, and we are going to show with the imaging and the angiogram how it looks and how we need to treat. Patient had an angiogram in the past few weeks ago, which Anu will show, and this area has a very unexpanded stent, and of course there is a restenosis. So those two things which will be shown here. So Anu, so you want to let me start with the angiogram first. The presentation before we go to the let's say start the slide. We go to regular one. Start the first one. We always need to thank our supporters. Yes, these are our supporters. Then disclosures, no change. This is the case number 165, 68-year-old male has with the CABG and PCIs and presented with angina and positive stress test. And he basically had a 4-vessel bypass after restenosis of multiple stents, including SKS of the LAD D1 bifurcation. And then basically came with angina. EF has few MIs, EF about 45% on good medical therapy, and did have a COVID last year, but SAQ score was 57. And in the graft point of view, here LIMA is gone, the vein graft to RCA is gone, but there was a jump graft from OM1 to D1 to OM1, which is or LPL, which is good. Patient therefore had a PCI of the RCA, and now today is for this unexpanded LAD stent of the SKS limb. Yeah. Okay, we can show the angiogram now.
So you see the LV gram, good. Yeah, normal, and
it's a 45.
Right,
it has been read at about 45-50% most of the time.
So you can see the right coronary artery was the Promus stent, which looks
two stents you put with all good.
So this is the left side, if you can see. The LIMA attachment you are able to see in the RAO view, the tenting, LIMA is gone. I'm just thinking, is there left main disease also? We have.
Well, imaging you'll find out with the imaging how much it is.
So now, before we did this,
in this view, it doesn't look good. I mean, it doesn't look bad actually. If you see that before on the fluoro, that's the carina of the two stents, the LAD and to the diagonal.
And then you see the under expansion stent, under expanded.
You want to magnify?
No, you can see it very well.
But on angiogram, doesn't look even stenosis. If you see that, yeah,
you do. Just look at that area. Yeah.
Actually, it looks quite here in the caudal view right there. See, maybe we can show that double layer, or we call carinal diaphragm. When the carina gets endothelized, you always see a white shadow, which somehow in this view you don't see.
In this view, you can see the LAD stent is underexpanded.
Yeah, clearly. LAD stent looks underexpanded right there
and then
at 12 o'clock.
When you inject dye, there is stenosed.
Yep. Okay.
Well, I think there is going to be both. I think there is instant restenosis as well as the problem of the underexpanded stent, which I think created it. But Samin, I think you're absolutely right. On the angiogram, the left main does not look too bad. Hopefully, the imaging will clarify that.
So I'm going to So the plan will be we will do OCT first, but then definitely rotational
You want,
atherectomy, right?
you want to magnify first a little more, or?
No, just there. Yeah, no, I think we do direct wiring. Understand.
Yeah, definitely in the middle at 12 o'clock, underexpanded stent. And so idea is to put a run through and
No, I'll
image.
do it on the Rota wire. OCT on the Rota wire.
Okay, OCT will be done. Okay.
Yes.
All right. So while getting OCT, let's go to our presentation. While we're getting ready for the OCT. So basically that is the plan now. Imaging guided, stage complex PCI of the calcific, expanded SKS of the LAD using Rota and likely IVL. Now, you did IVAS last time when you did the PCI of the RCA. What was the IVAS finding at that time?
Yeah, that also showed the underexpanded stent.
But IVAS went through.
Yeah, went through. Yeah,
Okay.
but it's very tough because a lot of acoustic shadow because of the two layer of the stent and the calcium. So, but anyway, underexpanded stent at the bifurcation.
You should have put the IVAS picture. Right?
Yeah, we can play. Let's put the IVAS on the. We can show that old IVAS. Is Elena there? So get the IVAS of last time. And on 214.
Anyway,
and
now
we can
we
put
have
on the disc.
OCT.
Yeah, OCT.
Let's
Yeah.
just, it's not going to make
Is
any
Elena there? Yeah, 214. Go and try to put an IVAS on the key. We'll show it. 214 IVAS on this case.
We are ready for the OCT soon.
So now question in this situation, IVAS is better or OCT is better? That's a question.
Yeah, I will. Kiski, what do you think?
For the this kind of mechanism of the instant stenosis, I think OCT is better. And even this is a severe calcified lesion. Calcium assessment is also OCT is better, I think.
But is there a definition of stent under expansion on OCT?
Just after the stent, like stent area 4.5 is the stent under expanded.
No, he's asking, do we have definition? We don't have definition. I mean,
Yeah, the
classification or
stent area
definition on
4.5 is the cutoff.
I mean, in this particular case, because of somewhat protected left main, you are normally you've stayed away from the left main with OCT, but this I think is a slightly different situation, which is what somebody has just asked also.
Yeah, and the same thing is also for the IVAS criteria of the left main significance. We know what lumen is for the, we know for the IVAS, some people say 5.5, some will say 6. But what is the OCT lumen?
No, we stay away from left main is distal left main we are able to visualize with OCT. But
Understood.
Ostial we cannot. That's
No, we are talking about
OCT.
distal left main. What is the criteria of the significant distal left main on
That's
OCT?
a question.
No, question is about the same. How would you diagnose the distal left main on OCT? That's what the question they are asking.
Plus,
So is there a number?
And the question
Yeah,
is,
actually the class 2 is just the IVAS for the
OCT
assessment.
That's the IVAS criteria, and that I know. Is there a OCT criteria of the lumen? Because OCT always looks like almost 1 millimeter lower than the IVAS. And clearly, as you saw, the guideline-wise, OCT, ostial, left main, OCT is not good. Will not evaluate
right?
that.
Yeah, good clearance.
okay, we are going.
So somebody, Dr. Harris has recommended, he says, what about
Yeah, beautiful
using
image.
stent boost?
Yes.
checking the
Stent boost we
image.
should show.
I don't know, it may go with all these external wires.
Yeah, beautiful
Yeah,
image.
now stent boost may not show because of these wires, and so that is correct.
Wow.
Right.
Okay,
But,
I will do the core registration first.
But there are few, you can cone down exactly in the mid area, and then yes. But anyway, let's go to the OCT.
Sure.
Stent boost is a poor man's OCT. Or IVAS. Okay, tell us what we are seeing now.
Yep, now doing the correlation, accept. Okay. I show you. So yeah, this is just after the diag, the lumen is open and come back. Yeah, this is, yeah, now I can see the second lumen. This
Yeah,
is
that's the
dia.
carina. So you
Yeah.
used to say 2 dumbbell.
Yeah.
See that? Classical my SKS.
Yeah, and
There
you
is a
see
stent
that,
in the diagonal, stent in the LED.
yeah, just a short axis like by 1.5, like underexpanded. And I can also see the calcium behind a stent.
Hmm.
So yeah, and I
Maybe
come to the
1.5
proximal LED. There's
Yep.
also the
1.5.
second
1.5,
lumen.
Okay, open one fiber. Yes.
So because of the calcium behind the stent struts and the proximal, we are going to do a rotablation and then decide add to IVL or just go to high pressure or just a cutting balloon. I think this is the case.
Yeah.
You need to crush the diagonal arm. Doesn't need now because there is a good graft from the diagonal to LPL.
One layer or 2 layers there? To me,
Okay,
looks one layer.
so very
One layer.
close to layer because
No.
okay, but okay.
Where are 2 layers? Proximally?
So now I see this is the bifurcation part. I magnify. So
So show that picture actually this dumbbell. Yeah, see there are 2 stents there in
yeah,
the
here is the first layer, the second first layer and the second layer. So it looks like this is a 2 layer.
So what we think, there was original stent in the
There was
LED,
original stent
and
in the
then we
LED.
did SKS of the
and
Yeah.
LED diagonal SKS. So double layer and see the nice 2 dumbbell.
Yeah.
Those are our classical of hallmark of the SKS, simultaneous kissing stent with the center carina. So we created the first separate carina and now the carina is endothelized. And then we published that you see a white shadow. So in this area. So anyway, so our goal is because of calcium, because of unexpanded stent, ablate it and with the atherectomy, and then we'll go to the next.
Dr. Sharma, the distal left main area is more than 8.
It's more than 8. Okay.
Yep.
So left main is not significant. Good.
balloon.
Yeah.
How much?
Balloon, give me a 3.5,
3.530.
not
Yep.
30.
Okay, 20.
20.
Yes, Samir.
What is the level of calcification and did the OCT even give us further guidance whether it is located to the intima or extending into the media?
Yeah, because OCT is the only one knowing that the IVUS will not tell you anything more, just the calcium or depth and so because of IVUS not penetrating. Tell us the depth of the calcium and
I
if there are
can see-
calcific nodule or what is it?
Yeah. At the level of the bifurcation, I can measure the calcium thickness. It's more than 0.5. It's a thick one.
Thick, more than 0.5.
Yeah.
So another very interesting question has come. I'll ask you after the rotablation.
Yeah.
Oh.
No.
You know what's happening is that part of the stent, right?
Yeah.
That's why I said 175.
Yeah.
The diameter was 1.5.
But
So,
it's a chance of getting bur
Yeah,
stuck,
bur stuck.
in more. Yeah. So this is the 1.5 bar, which meticulously went through.
you want to do OCT after or just go forward? Okay, come out.
Okay.
And
Same.
the question is how to differentiate between negative remodeling and underexpanded stent.
Yeah, definitely the stent, the shortest axis is 1.5. Definitely underexpanded stent.
Yeah.
OCT
So question is very simple.
Run through.
Yeah, that negative remodeling versus underexpanded stent. So basically what you're trying to see is that's where the issue may come down with the plaque burden and so, but stent expansion, underexpanded stent will be very clear that your lumen minimum stent area is 4.5 or 5 or 4. So a lot of people say your minimum stent area should be more than 80% of the reference vessel. And distally and proximally. So many times we know that stent distally may be 4.5, proximally is 5.5. So it has to be more than 80% of the proximal or distal minimum stent area. So that is the expansion. Now, the many times with the positive remodeling, what you will see is the stent now not opposed and not opposed to the wall, and sometimes maybe poor expansion also. But key is that once you get a lumen, by definition they say more than 5.5 in the epicardial vessel of 3O. The mode 2 of more than 5.5, that is your full stent expansion, and less than that is your stent under expansion. And both, I would say, for the clearly OCT will be a better tool to make the diagnosis of the stent under. I mean, more so for positive remodeling, because that will be tough to know with the our IVUS group. Okay, now after the Rota has been done, Anu is wiring with the run-through wire, and Rota wire went easier than the run-through.
Went very easy. So here it could be also that we lifted. You see that?
Part of a plaque or something.
And
No,
not
no,
only that,
stent,
you could be the two things. You could be in the top carina, other part of the lumen, because that lumen is closed at 1 o'clock position.
Yeah. Now we
With
got
the that's where the our diagonal is. But that's okay. We're not worried about the diagonal now. And
Yep.
Should we do OCT again or move on with the IVL?
Or we can check the balloon dilatation, balloon reaction. Because just the OCT, just the rotors.
Yeah, Rota.
Yeah.
he's
maybe
saying, I think we
check
should
the-
do something
how much
additional.
ablated.
No, let's do IVL now straight, right?
Yep.
Yeah.
Um,
I think
The
you-
vessel size is 3.5.
3.5. Yep.
give us 3.5
Yep. We can remove the Rota wire. There will be a
because
tough
doing OCT now is not going to tell us anything.
yes. So I can tell you those kind of algorithms are needed for us interventionalists for OCT and IVUS, that you have done the initial based on the, AI algorithms are so powerful nowadays. So you have done the baseline and then you have done the work, rote ablation, IVL, and then you repeat that imaging. That imaging tells us, yes, you are done or you need to do more. So this is where we are lacking, I would say, from our scientific point of view. We did a small syringe.
Maybe ChatGPT is going to tell us soon. What are you doing?
In case you inject.
No, we use this. Oh, for the
Corner injection, yeah. Okay, so we are getting 3.5.
no.
This side.
Yeah.
Yeah. 3.5 IVL is getting ready. And it should go easily, knowing that the Rota bar went in.
Let's see.
Well, based on the data from the OCT, I think your prediction is going to be right. Samin, have you had the chance to use orbital atherectomy for these cases?
Yeah, so I would say that we did in the beginning, and we found that orbital atherectomy does not work for unexpanded stent. We have published paper for ISR. Orbital atherectomy for the ISR alone, yes, but not for the unexpanded, because I think this atherectomy work on the unexpanded area because of by generating the heat, and orbital does not generate the heat. Go. So this is 3.5 has crossed it.
Okay, go up.
Yeah.
Okay, good. Yeah, 4.
4.
Right?
You hold it.
Yeah, good.
No, let him do.
Okay, hold on.
One person do one thing. Yeah.
Ready. Going.
So proximal area has not opened up. Mid area has opened up.
We are not sure to the stent one up.
It was 4.
Okay, go.
Go to 6
6.
and down.
No, wait. Go up. 6.
Yeah.
Yeah,
Good.
wait. Not like go up and come down.
No, you have to come
Transmit.
down. Yeah. You want to go to 6?
Yes.
Good. 6. Fine. That's okay. But deliver at 6.
Down. No, I'm not delivering.
No,
this.
what?
Down. Okay, go up 4. Good.
Now in a very calcific lesion, a lot of people say just do the IVL and now I go back with the stent. No,
6.
you need to enlarge, still do the post dilatation
Okay, down.
before you put a stent. So in the disrupt CAD,
Down.
they actually did a pre-dilatation in 54% of cases, and the post-dilatation number was not shown.
Go up.
Actually, that how many times they did a post-dilatation after the IVL. After the stent, yes, everybody was post-dilated.
Okay.
But only the pre-number was shown. Maybe I had to look into that paper a little more. That how many were post-dilated after the IVL. Because I think if the IVL balloon is fully expanded, probably you don't need to post-dilate. But if the IVL balloon is not expanded, then definitely you have to post-dilate before you put a stent.
Okay, I think that's good. Yeah. Okay. I think it's expanded,
Yeah,
right?
right.
I'm going to come a little bit further here. Okay. Now you go up here. 4. Most of the IVL cases that are done with imaging, right?
Yep.
We have done pre and post imaging. And once we know the balloon has expanded and we have done OCT, we have seen a nice disruption of the calcium. We never did post after that, does the stent, and it shows a good expansion. So we had to give a few runs. Can you do an angiogram now, right?
Yep.
Yeah, let's go. Ready? Okay, good.
No, we're
No,
doing
it's
it.
okay, it's
Yeah.
okay. Go. Go. I
Looks
think
very
it
good.
looks very good now.
Yep.
Now you want OCT?
Yeah,
Yeah.
now it's a good
Okay,
case
good.
for OCT.
Anu, how many trains did you use?
3. Actually, no, 4. 4.
Four. So now try to see in a little magnified view, or you know what
No,
they
you can
suggested?
see it. You can
Yeah.
see it right there.
That it has opened up. See that I have to just do a fluoro for them. Yeah. See that area exactly at 12 o'clock has opened up more. And what people wanted to just zoom in.
You will not see it with the when you have the sternal wires.
Yeah, sorry. Yeah. So no question is it has to totally zoomed in to the
We're more
stent only.
towards the 1 and 2 o'clock position, no? Rather than
Yeah.
even 12.
Right. Here. Okay. Now do a zoom, stent boost. No, just try one. Done?
Stent boost, man. It's on the OCT.
Yeah, total waste of radiation. We wanted to just show that once you have all these things, you'll not be able to see. Okay. So OCT going back in.
I think it's going to show significant expansion of the stents.
Okay. Hold it.
Yeah,
Good, right?
Yeah, good clearance. Yeah, beautiful image. I'm checking.
Okay, now what you want to do? 3-5?
Yeah, now it's
We have a
distal
3-5. Post dilation was what?
consider-
3-0, 3-5 we have.
3-5.
Okay, give it to me.
Yeah, much better expanded.
Wow.
Yeah.
A clear difference.
Very good, Lima.
Now,
Yep.
do you see anything change in the calcium that was behind the stent strut?
1 second. And I will show you the bifurcation. Yeah, here you see the calcium fracture behind the stent. The shock wave goes through the stent, and there is a fracture behind the stent. Here,
Okay.
at
Very good.
6 o'clock.
So then just put a stent.
And
then post dilate.
yeah, definitely the stent is expanded. The
Because
pre
it
was
crashed
1.5,
the-
but now expanded to the
This was only
2.5.
6 atmospheres.
It worked.
I think
Now-
we should have just done IVL.
That
rather than-
carina which we had, has that been pushed on one side now?
No, we could do more.
That with
Still
the
see.
we are going
Yeah.
to do with the high pressure now.
Yeah, yeah.
3.5.
I mean, here we need high pressure to
Yeah.
just to crush the
No,
carina.
carina became
Otherwise-
small. No, other
Otherwise,
side.
yes, we could go ahead and directly stent it.
Anu, are you planning to do something on the more distal segment after the large septal there?
Go. I mean, no plan.
Okay.
Did
Go up.
OCT cover all that? Yeah, just, show with the OCT. I don't think that's go.
Is there any lesion there in the distal?
22.
Yeah, actually here's also like some ISR lesion. The area is around like 3.5. But not super tight, the distal part.
Is this
Down.
post dilatation or are
It's a
you
3.
going
No,
with
it's a 3.520
Stent.
post dilatation balloon.
balloon? Okay.
And
perfect.
yeah, so and then we'll take a 3.528 because it was use a Promus on the other side. We try to use the same.
Okay, nice case. Yeah, down. Underneath, a little specule is still there. See that?
Yep. But we have to dilate there now.
Where I did. We went to 22. Here. I think we were good there. Now you're saying put a longer stent? Because we did not do anything distally.
Let's take a good picture now after this dilatation.
Because if we need something, then we have to.
Oh.
You're saying just at the level of the septal?
Yeah.
Yeah, right there.
There is a
We put
disease,
that
mild
there.
disease there. Yeah. So just dilate with this balloon and put a stent.
And then we need a 32
32.
then.
3.5, 32 Promus
Yeah.
Elite.
Dr. Kinney, the
Yes.
double barrel start at the ostial LAD, so I think it's better to cover the ostial.
Ostial LAD, what's there?
Yeah, there's a double barrel. Looks like
Yeah, we
huge
know that.
dissection.
Good.
Okay, down.
Okay, give us the stent now.
That is why even Rota was getting stuck. The wire was getting into that other barrel. Go up here.
No.
We are going to touch that double barrel, okay? 24. So in that situation, don't you think we need 38 from ostial LAD all the way down?
Yeah,
Use
by
38?
OCT also ostial LAD to the after the septal lesion, it's gonna be the 37. So 38 will cover the
Yeah.
entire
Good. You
lesion.
go with the 3.5,
Visual,
38
go
then.
on. Our visual and OCT matching.
Yeah.
Nice.
And in this case, circ is non-existent because all fills by that LPL collaterals. Vein graft to LPL fills the rest of the circumflex.
Down.
So it's kind of even distal left main you cover, it's a LED rather than the left main.
Okay. So 3, 5, 38 ostial LAD to the first septal.
Yep.
I don't think we need another picture.
No.
What we'll do is we'll do the stent and then we do the OCT, or do we need to post again?
No, I think we have done enough pre-debulking.
Yes.
So our plaque modification, we do the stent deployment
And
at
then do
16
OCT.
atmosphere, then we do the OCT. And then that's the enough for the OCT. 3 OCT per case is maximum, should be.
Toxicity. Okay, let's. Oh man, yeah. Good. Okay, ready?
Pull back
Connect.
few millimeter, even this
I
is too
think
small.
some die.
Yeah,
That's right, SS.
2 millimeter back.
No,
Just
no.
the left main you have to cover. Yeah, ostial LED is covered. Good.
Okay, go Cine. Go. I think we're good.
Good.
Right?
Very good. Yep.
Okay,
Go up.
go up. He said 16. OCT ready?
Yep.
Down. Go up again.
Here, large vessels, you have done a plaque modification, then you put a stent, go to high pressure. I think that's okay. You don't need to go further. A small vessel, vessel less than 2.75 or so, and long stent, you definitely should post dilate. Always.
Uh-oh.
Many of those small vessels, soon we will be doing the drug-coated balloon. Right now, drug-coated balloon trials are starting, both paclitaxel as well as sirolimus. We are part of the sirolimus, but they are doing it only for the ISR first. Once they complete the IRS enrollment, then they will go to the native vessel bifurcations and so.
What has been your experience just based on these cases?
No, but we are not using just. I would say our first case will be in mid-April because FDA, our IRB just approved it. They had to start the site initiation, then get ready. So I would say first case probably will be in the mid-April. But based on the literature, a small vessel diabetic do better with the cutting with the drug-eluting balloon compared to DES. Maybe non-diabetic probably not a difference, and large vessel still should be the DES as a default strategy. But in the drug-coated balloon or drug-eluting balloon is taking a, big, I would say, a wave in Europe and other places.
Probably in India also with this new company, Vascular Concepts, I think that's the name. Or I was wondering if you saw any of their cases at the India Live meeting.
Yeah, so actually India Live meeting, there was one case of the drug-coated balloon was shown. There were many cases of IVL were shown. And we relayed, Anu relayed the case of the rotablation. The only case of the rotablation done in those 32 live cases, 34 live cases which were done. Of them, actually 12 were the structural cases.
Yeah, good clearance. It's ready. Yeah, beautiful. Checking. The mid LED.
Okay, tell us now, Kiski, teach us what do you see and what we should do more.
Check. 1 second. Yeah, stent is expanded. I am checking the proximal edge also. Yeah, the stent just start at the osteo, perfect stenting. And
so bird's eye view, I don't see any red spots, which means
put the stent on the horizontal frame.
Yeah, so this is the proximal. It looks perfect, normal position, well expanded. And at the level of the diag.
Now, what is this area? No.
Yeah, here, this was the tightest part, but now the area, I will check 1 second. Yeah, it's 5.1. It's
So
more than
should we
4.5.
dilate that area?
5.1?
Yeah.
Yeah, the tightest one.
I mean, you want at least 5.5.
But more than 4.5 is okay by the OCT criteria. And this was a tough lesion, the 2-layer and expanded outside calcium. I think we did a great job.
Okay,
yeah, hold it here. See that double barrel? One side has been pushed completely out now. Yeah, see? It became very small.
Yeah,
right there.
true.
Double barrel, yeah. But I think if you have the balloon already, just go with a 3.5 in the middle.
You need a 375.
Okay, 375, 12 or 15, yeah.
Yeah, right? 375, 12.
Good.
Yeah.
So just that area to improve. I think that's just more of a imaging point of view. I know that I'm sure you do. I was that lumen will be more than 5.5. It is 5.1 on the OCT.
4.5. 4.5 is the cutoff. Yeah.
So that will be 5.5.
Yeah.
Kiski, the area which had the proximal dissection has been completely covered, no?
Covered. Yeah, true.
Yeah. That has been covered. Okay, so with that note, let's go back. We just complete dilatation. I think from interventional point of view, we are done.
Yes.
Let's go back to our slide presentation. We have full 15 plus minute. We have a lot of came out from the ACC and particularly our landmark trial from Sinai. And of course, Anu presented one vessel disease, although this was a post-cabbage case, is appropriate. So what our points are? One, the key 3 interventional trials from ACC. Host idea, renovate complex PCI, both were done from Korea, and yellow 3 from Mount Sinai. These are all late breaking trials, and having a late breaking trial from single center was remarkable with the yellow 3. Then focus review of the month is beyond coronary artery stenosis and stable ischemic heart disease, the evolving management paradigm for stable ischemic heart disease patient.
I don't need any more OCT.
So first is the host idea. This was host group. Remember, they had done many trials, and this was a comparison of 3 months DAPT versus 12 months DAPT after the newer ultra thin stent or zero Coroflex ISR, and basically 2,000 patients randomized to 3 months and 12 months are exactly identical MACE as well as bleeding. We shown here. Overall primary endpoint was the MACE of death, MI, TLR, stent thrombosis, and major bleeding. whether it's a 90 days or beyond, both were identical. And of course, individual endpoints are here. Target vessel failure, lesion failure, and bleeding were identical 3 months versus 12 months. And this basically showed that whether you use clopidogrel and about 10% were on the P2Y inhibitor, strong was identical. So general overall showed that 3 months DAP is non-inferior. So that's basically what we learned from it. Good. Now, this goes little against what has been in the literature, where the trial compared 1 month DAP with a 12-month DAP. Stop DAP to ACS. You saw 1 month was higher MI rate and similar data in the 1 month DAP trial that you see in the ACS patients. There's a little higher event rate in the ACS patients. So therefore, I would say that what we learned from the trial, trial, that 3 months is okay. But even ACS patient compared to 1 month. So not 1 month, 3 to 3 months is the maybe the new 12 months which it is. Second was the imaging guided PCI versus angiographic guided renovate complex PCI again from Korea, and large number of patients, 2,200, and with a 1 year follow-up of the complex cases. And they define complex in various ways, 9 characteristics. 1, true bifurcation, CTO, left main, stent length of more than 38, multivessel disease, multiple stents, in-stent restenosis, severely calcified lesion, and osteal lesion of the LAD RCA or circumflex. So these kind of, I would say this would be like 80% of your lesions, which would be complex PCI, 2-to-1 randomization. Primary endpoint was composite of cardiac death, MI, and clinically driven TVR. And of course, you see IVUS was done in 75% of cases and OCT in 25. Now, in the angio-guided arm, only 2.4% IVUS was done. So overall, basically what we learned, angiographic guided, your primary endpoint of TVF was 12.3, became almost half with the imaging guided. As you can see, 36% reduction of event and endpoint of TVF without procedure MI is the same, again, about 41% reduction from 8.7 to 5.1. These are the individual endpoint. TVF, death, MI, TLR, stent thrombosis, 0.7 went down to 0.1. And of course, the AKI was no different. There was higher procedure time, higher fluoro time, slightly higher dye use in the imaging guided PCI, but did not translate into the AKI as shown here. And these are the various individual endpoint, and where it showed the major difference that if you see, I was made a little better difference than OCT. OCT made a better difference than IVUS. You can see the curve a little more separated from the midline, and also in the complex lesion. Once you're talking about the true bifurcation of the left main, those were the more got a better benefit, and the osteal lesion and severely calcified lesion. Now, then benefit was more in the stable ischemic heart disease compared to acute coronary syndrome. I mean, this is a little paradox, and also in the patients who are older and also patients who are female. So clearly, I think part of that is because we undersize those vessels. The same thing, another one, that diabetic, if you're no diabetic, you get a better in the imaging. I don't understand that part. I thought diabetic should be, but this is the way we have it, and others were shown in the screen there. So therefore, now also they said, if you do a better optimization, imaging guided, one is the angiographic guided, which is 12.3%. If you did regular imaging, it's 8.9%. But if you optimize it, stent optimization with the imaging, it became 6%, almost half. But overall, it means, and then they have OCT versus IVUS. As I mentioned, OCT data were a little stronger than the IVUS in this. That was not randomized. So basically showing that complex cases will do better. And we showed that point last month that ACC, our American College of Cardiology, the recommendation consortium that we should be doing more imaging guided PCI, particularly complex cases. Then I'll just ask now Anu to present the data of the Yellow 3 study. She has done Yellow 1 and Yellow 2, looking at first the oral high dose statins, and then the randomization, then high dose statin, and now did using the PCSK9 inhibitor in the patient with a stable coronary artery disease.
So Yellow 1 was, we randomized standard of care to high dose statin. Again, we did it in obstructive lesions. And only at 8 weeks they came back, showed that aggressive statin therapy was better by decreasing LCBI. That was yellow 1. In yellow 2, we used OCT, obstructive lesion, again 8 weeks, but there was no randomization, we only used statin. But in yellow 2, we also wanted to understand how plaque morphology changes, so we added cholesterol efflux, as well as we did genetic analysis. So having done all that, which we went on to again stable CAD, now this time we used PCSK9. So we know PCSK9 has been used in stable CAD in Glagos, where it showed that percent atheroma volume decreased by IVUS. In STEMI, non-STEMI, they had used optical coherence tomography, and both in Huygens, they showed that FCT, which is fibrous cap thickness, improved in non-STEMI patient, and LCBI decreased in PAC AMI cases by using. So ours was 26 weeks of avelumab in patients who had stable CAD, and then we did OCT nears. That was our goal, having done yellow 1 and yellow 2. The primary endpoint was minimal fibrous cap thickness assessment by OCT, as well as lipid core burden index at 4 millimeter by LCBI. These were the primary endpoint. How will it change after 26 weeks of evolocumab? Secondary endpoints were various OCT parameters, then IVUS parameters, and we did the gene expression in these patients for at baseline as well as follow-up. So very intense study. Stable CAD who had to be on statin for 4 weeks. So if you see, if they're low to moderate statin, then LDL had to be more than 80. High dose statin, LDL had to be more than 60. If they were statin intolerant, LDL had to be more than 100. So when they had non-obstructive disease, that was a culprit vessel that we took for the study. We did OCT. So the entry criteria was very strict. We had to make sure there was a lipid-rich plaque. Lipid arc had to be more than 90, and fibrous cap thickness had to be less than 120. So if we did not see that, patients were excluded. Once they were included, we did nears baseline. Then everyone got evolocumab 140 milligram sub-Q every 2 weeks, and their original statin dose was continued for 26 weeks. They came back for follow-up. We just did the imaging. So they had clinical follow-up of 1 month, 6 months, 12 months is still ongoing. Will finish end of October. So if you see here, mRNA analysis has been done at baseline and follow-up. So 137 patients were enrolled. 8 were statin intolerant, 110 completed 26 weeks follow-up. Of that, 7 were statin intolerant. So 27 excluded for various reasons, means they did not come back for follow-up. So we had 110 patients who completed a follow-up. So the baseline characteristic of 137 patients, complex patients, if you see here, at least half of them were diabetic, and all various vessels were imaged. So the biochemical measures, if you see, total cholesterol decreased, but LDL 96.8 decreased to 39, down by 57 points. Similarly, if you see that HDL, some improvement, not a lot. HCRP was no different, as well as triglyceride, there was no difference in these patients. And we know that HCRP difference is usually seen on statin patients only, but PCSK9 has no effect on CRP. So the primary endpoint of imaging, so baseline fibrous cap thickness was 70.9, increased to 97.7, absolute change of 26 points with significant p-value. So the so-called TICFA, where we say fibrous cap thickness has to be less than 65 micron, was seen about 48%. Half of the patients went down to 13%, again significant. And 80% of the patient increased the fibrous cap. About 20% there was no change, and that was what we call them as non-responders. So with the nears, same thing, 306 at the baseline, decreased to 213 with the absolute change of 93, and about 76% had decreased in the nears, and I would say about 24% of the patients were non-responders when it comes to nears. So this is just an example, baseline case of 60 micron OCT. If you see that follow-up, 90 micron, significant change. When we did the fibrous cap thickness based on other parameters, if you take a strict criteria of your baseline fibrous cap thickness greater than 84, which was about 26% at baseline, even with that strict criteria, we saw that at follow-up there was improvement in the fibrous cap thickness in these patients. So this is a nears. If you see 782, that's a chemogram where you just get a number, decrease to 235, that means a change in the lipid, significant change. So other secondary imaging endpoint, so important is all the lipid parameters change. Macrophages also change, which is actually the arc, the length. This is a surrogate for inflammation, and you see that decrease at follow-up, and calcium, which we know that. So when the lipid changes, how the plaque heals is that you start seeing an increase in calcium. Our calcium length increased, which was also significant, 6.4 to 6.7 with a p-value of 0.03. So this is secondary IVUS, percent atheroma volume, decreased by 1.3. So in most of these studies, it ranges between between 1 to 2. So we are about 1.3. Exactly like the other studies, and the lesion, the entire lesion nears also decreased 139 to 90. This is a plaque stable case where I would say there was a change in the plaque morphology. LDL at baseline 80 came down to 34 at follow-up. If you see that, this is the prox circumflex lesion, which is a non-obstructive on angiogram, 60 micron at baseline, 90 micron at follow-up, and LCBI 782 decreased to 235. We have been calling this as a melting butter sign. You see like a nice piece of butter sitting when in the baseline, completely melted when they came back. And plaque volume, which was 48, decreased to 45 at baseline. So we call that like a responder patient. And now the LAD, non-obstructive, mid LAD, 50 micron to 50 micron, same, remained the same. Look at the LDL. Baseline was 80, yes, and follow-up was 7, but no change. LCBI actually improved, increased 586 to 690. No change in plaque volume. So this we would call as a non-responder patient on the thing. So just we concluded that this is the first study to be done on stable patients who got evolocumab for 26 weeks, resulted in significant and substantial increase in a minimal fibrous cap thickness by OCT, and reduction in nears, and reduction in percent atheroma volume by IVUS in angiographically non-obstructive lesion. And the prevalence of vulnerable TICFA lesions reduced from 48 to 13%. So if you multimodality imaging report of stable patient in non-obstructive lesion and lower level of LDL at baseline compared to previous studies further supports that aggressive lipid lowering in this patient population is important. At 6 months, 20% did not demonstrate a change in fibrous cap thickness, and 24% did not see any difference in LCBI reduction. So very important is the gene expression, which the data being analyzed right now will tell us that who are the responders, non-responders, both to statin from yellow 2, and in yellow 3 we will know responders, non-responders to PCSK9, and our yellow 5 will be where we are comparing yellow 2, yellow 3 data, and then figure out exactly who are these responders, non-responders, and then probably come with some kind of a biomarker to understand who are these patients, then subsequently probably aiming for personalized medicine in this complex patient population.
And that will be tremendous, as you know, that every aggressive statin trial, 2-year follow-up, still event occurred in about 18-20% of cases. So clearly that we need something that who responds and don't respond. And if we come up with some kind of a biomarker, which is the kind of a I call it a jackpot. If you can find that, will be a great. Yes, Samir, your comment?
Yeah, Anu, congratulations. I mean, this is a multi-dimensional, very forward-looking study. I'm aware of a lot of your research work. This probably is right on the top. I mean, the areas which you are looking into it, this is truly the future, not only of, I think, interventional cardiology, but preventative cardiology. The areas which you have been able to hit targets in 137 odd patients. It's my congratulations to you. I know this is just a 10-minute presentation of a 10-year work. So congratulations. This is outstanding and very, very forward-looking.
Beautiful.
Thank you.
And having a single center study where the late-breaking clinical trial in the ACC itself has so much significant validity. So second of our focus review of the month is beyond coronary artery stenosis and stable ischemic heart disease, evolving management paradigm. And this actually is written none other than Dr. William Bowden, who has been a big proponent of ischemic treatment, non-interventional, and he has a very nice review article. I think we have a lot to learn from it. And I think it's, if you read the management of stable CAD has been based on the assumption that flow-limiting atherosclerotic obstruction, that our coronary stenosis, are the proximate cause of angina and myocardial ischemia in most patients and represent an important target for revascularization, for which we do PCI and CABG. However, the role of revascularization reducing long-term cardiac event in these patients has been limited mainly to left main 3-vessel disease, diabetic, and decreased EF. Mounting evidence indicate that non-epicardial coronary cause of angina and ischemia, including coronary microvasculature dysfunction, vasospastic disorder means vasospasm, and derangement of the myocardial metabolisms are more prevalent than the flow-limiting stenosis, raising concern that many important causes other than epicardial CAD are neither considered nor probed diagnostically. So this is basically, we've shown that multiple mechanisms exist, and they're basically what we have been showing, the approach of management including non-invasive testing, lifestyle interventions, goal-directed multifaceted medical therapy is evidence-based and often effective in patients with stable CAD, and he was really clearly the founder of the our CARIS trial. And of course, all these pharmacological and procedural approaches to stable CAD are complementary and needed to have a best outcome. And also we know that you do an angiogram, non-obstructive CAD. So ischemic and non-ischemic, non-obstructive coronary artery disease, INOCA and MINOCA, have come up into the equation now, and CCTA. And therefore, to really dichotomize, which is now the latest recommendations are, that when you see the patient, your screening test is CCTA, coronary CTA, period. And then we do something later. If you find something, then you decide about stress perfusion, PET, functional angiography, pharmacological testings, and so. But entry point is the CTA as it's been shown. So this is a very nice diagram, pictorial, that patient stable angina, you did a CTA, and occluded stenotic coronary in 1 in 5, 20%. And these are the patients who will go for medical therapy or will go for stent or bypass. But non-obstructive lesions are present in more than 2 in 5 patients with a small vessel disease, mostly in women. And what happens is, there often specific tests are not used. That is what is the microvasculature dysfunction or coronary vasospastic disease. And of course, question is how to treat these patients. The patients keep coming back, readmission to the hospital, cardiovascular event goes up. So basically the nice pie graph, obstructive CAD, about 20%, INOCA, and the microvascular disease but no spasm is another 20%. INOCA with the microvascular spasm is 20%. No epicardial CAD, no microvascular disease and 20%, and non-obstructive CAD and no microvascular disease another 20. So it's kind of a 20-20-20 of the 5 categories. So key is that what you do. So we learn is that not only now you're ruled out epicardial disease by the CTA, but you need to go beyond. Patient is symptomatic. They come back, have a higher coronary event. So therefore, now you need to go to more functional, multimodality imaging of the PET CTA, dynamic CTA, And then, most important, they saying that CTA has to be part of it, and this will be evaluated in many of the randomized trial going on. So this actually has been the focus of our ACC/ASA guideline. Remember the last year, in 2021, which showed that emphasis on prevention and future consideration, many of the medical therapies in hypertension treatment, statins, non-statins, Stent, it's ethyl, they're basically fish oil, ACE inhibitors, rivaroxaban, SGLT2 inhibitor, colchicine, all have shown based on the patients, besides taking care of the obstruction, these all additional medical therapy, multifaceted medical therapy improves overall patient outcome and control of risk factor, allow patient to live longer. And studies have shown that 50% of these patients, only 50% of the patients follow the medical therapy after the revascularization. So this is basically, I have put it together. Patient one is the occlusive CAD. Basically what we do is the treatment point of view, our goal is to reduce effort-induced angina by decreasing the heart rate, beta blockers, and calcium blockers, and so on and so forth, and various those renolozine and so. And of course, the coronary vasospasm coming up with a factor. Then there are some dedicated treatment for microvascular dysfunction. And most of them are basically related to nicorandil, which is not available in the United States here, but available outside, and other non-dihydropyridine calcium channel blockers and so. So microcirculation is important. This little complex slide, but it basically puts it together that in the center, you have done the CTA, and from there, you decide what to do. Basically, you have left main excluded, then it's fine. Then you can try your medical therapy. So key is, while ischemia trial succeeded, because CTA excluded the patient with the left main disease. That's the key. So left main has to be excluded, and then you go through your regular medical therapy, and then FFR or IFR based on for revascularization, higher value, you leave it medical therapy, lower value. So even if you have FFR, IFR negative, what does that mean? It's just telling you non-obstructive lesion of the epicardium, but there's still a lot of functional issues. So you do then vasospastic, microvasculature, CMR, IMR to answer this patient's issue. So this basically, just to take it from there, they put it very nicely. I had to read it, little complex, that where do we go from here? We understood these. We very rarely, we are so happy we tell the patient you have no blockage, go home. But it's beyond that. And that is what we need to say, that it's not the obstructive disease which is causing angina, ischemia. There are many other factors. And don't call it as a non-cardiac. It's a non-epicardial, but still coronary and cardiac disease which is causing this acute and chronic myocardial ischemic syndrome. And this is very important that we need to identify these diseases because they have a slightly different treatment. Vasospastic will not respond to beta blocker, will require special calcium channel blockers and so. And then more important is this, we must invest in developing newer management strategies and healthcare delivery models that may better align with treatment proven to benefit patients and society. Proven secondary prevention strategies and lifestyle intervention is contemporary guideline-directed medical therapy continues to be underutilized. In the United States, 40 to 50% eligible patients gets it. That means we have to lot of work we need to do besides just opening the coronary arteries. So that is what point is, underscore the importance of preventive therapy who has undergone CABG or PCI to improve overall long-term outcome. And therefore, there has to be a rebalance of patient management or not view procedural pharmacological intervention as competing treatment, rather complementary to improve overall outcome of the patient. So there is a need for a more inclusive management paradigm that uncouples the singular association between epicardial CAD and revascularization and better aligned diagnostic approaches that tailor treatment to underlying mechanism and participants of angina and ischemia in contemporary clinical practice. So very interesting. So let me put this together. 3 months versus 12 month DAPT after new generation DES, many of them acute coronary syndrome, thumbs up. PCSK9 inhibitor to reduce TICFA and LCBI and stable ischemic heart disease, 2 thumbs up. And then intravascular imaging improves MACE in complex PCI is 3 thumbs up. So Anu is saying why not 3 thumbs up in the PCSK? It will be 3 thumbs up when it show the outcome. So out 3 thumbs up is only for the outcomes. That's where the real life is. There is a mounting evidence that non-epicardial coronary causes of angina ischemia, such as microvascular dysfunction, vasospasm, derangement of myocardial metabolism are more prevalent than coronary obstruction. These factors are not routinely considered in diagnosis and management of ischemic heart disease. Clearly, there is a need to manage CAD beyond relieving obstruction to overall improve prognosis of patients with stable disease. So let's go to 3 questions. Renovate complex PCI, comparing imaging versus angio. What is the false? Lower TVF with IVI versus angio, lower TLR with IVI, similar stent thrombosis with IVI, lower MI with IVI, and lower death in IVI. Clearly, answer is not similar stent thrombosis, lower stent thrombosis, 0.1 versus 0.7. Second, following statement is false regarding the results of Yellow 3 trial, except significant reduction in LDL, reduction in TICFA, significant reduction in LCBI, significant reduction in macrophages and OCT. All patients responded with reduction in TICFA and LCBI. That's the wrong answer because 20% of the TICFA, 24% of the LCBI did not respond. Lastly, following statement is false regarding the evolving paradigm of the ischemic heart disease. Majority of the angina symptoms are not due to coronary stenosis. Microvascular dysfunction is a common cause of angina. So this is guideline directed medical therapy is practiced in minority. Vasospastic angina is a rare cause of angina, and revascularization is beneficial in left main and 3 vessel. Vasospastic disease is not rare cause of angina. It is there and more so in women. And we actually have started a protocol testing these patients with a non-epicardial stenosis, negative FFR, getting the vasospastic by giving acetylcholine, and testing for the microvasculature IMR and CMR with the Coventis test, equipment by Abbott, and we actually got Joe Sweeney, one of our associate, who was very much involved. He has taken this program, we have taken this program to the next level that patients are being referred to us now for microvascular testing. With that note, I'll complete our presentation for today.
I mean, a very comprehensive and detailed review. We had actually preset this last month by reviewing the ACC guidelines. Now you've got a lovely follow-up paper. Anu, congratulations on Yellow 3. Outstanding work, and good luck with the follow-up. We conclude our session here with the final message that I firmly believe that we now, through IVL, have possibly a very reliable and a definitive treatment for the underexpanded stents, something which had been kind of lacking before. With these words, we conclude, and we'll follow up during the next session on April the 18th.